She is actively involved in activities related to the child welfare and safety as a member of the Adaptation Committee in Northern Province, as a chairperson to the multidisciplinary team of child protection issues in Northern Province, as a member of the executive committee in community outreach programs of cerebral palsy and autistic children, and actively involved in the care of needy children in receiving homes and with chronic disabilities. She is a senior trainer at, at national level training of pediatricians and emergency physicians, and a trainer in advanced pediatric life support program conducted by the Australian Resuscitation Council. Professor Geethanjali Satyadas holds a postgraduate diploma in medical education from University of Dundee. She held important positions in the Faculty of Medicine, University of Jaffna, as the clinical coordinator, the chairperson of the Curriculum Development and Evaluation Committee, head of the Medical Education and Audiovisual Unit, and as the coordinator of the Internal Quality Assurance Cell. She is the current president of the Jaffna Medical Association. May I invite Professor Geethanjali Satyadas to deliver the prestigious C.C.D. Silva oration.
Ladies and gentlemen, let's give a round of applause to Professor Geethanjali Satyadas. Professor Satyadas will address you now.
The President, Sri Lanka College of Pediatricians, Professor Devasiri, Council members of the Sri Lanka College of Pediatricians, members of the family of Professor C.C.D. Silva, ladies and gentlemen. I consider this as an honor and privilege to deliver this year's Professor C.C.D. Silva oration, and I thank the President and the Council of SLCP for giving me this opportunity. I dedicate this oration to this great personality, Professor Chamli Chalmers de Silva, who served this country as the first professor in pediatrics. Professor C.C. de Silva had his education at St. Thomas College, Mount Lavinia, and entered Ceylon Medical College. He completed his degree in 1928 from UK. He obtained his MRCP in 1931 and MD in 1938. He returned to Sri Lanka and worked as a general practitioner from 1931 to 1949. In 1949, he was elected the president of the Ceylon branch of the British Medical Association, which is now the Sri Lanka Medical Association. That same year, he was appointed as the first professor of pediatrics of the University of Ceylon. He remained there till 1966. He was also the president of the All India Pediatric Association in 1954 and the president of the Ceylon Pediatric Association from 1955 to 1957. Professor C.C. de Silva contributed immensely to community pediatrics and pediatric nutrition. In 1957, he founded, together with Dr. Abhay Ratna, the largest convalescent home for children at Kalagulla. This institution stands today next to the North Colombo Medical Faculty. He also founded the Nutrition Society of Sri Lanka in 1975. He was a great writer and was in the editorial boards of the journals of Tropical Pediatrics published in London and Clinical Pediatrics published from the USA. His writing skills unfold in several books, namely Mother Your Baby, Outsteps the Dawn, and Life as I Lived It. He had a vast library and donated part of this to Jaffna Public Library when the library was burnt in 1985. As an educationalist, Professor C.C. de Silva had a vision way ahead of his time. This is evident in his farewell lecture entitled "What's Wrong with You and Me?" delivered to medical students of both Colombo and Peradeniya. Professor C.C. De Silva introduced the continuous assessment, small group discussions, and limiting lecture hours in order to enable more hours in the wards. He was a clinician, a researcher, and a great teacher. Although I was not privileged to be taught by him, both my parents have been taught by him, and both of them vividly remember how he insisted on taking a nutrition history in patients. He loved the medical students, and that love was clear when he invited the whole group of final year students to his estate in Kaduwala for a grand dinner which ended with song and dancing. Looking at the bibliography of his publication, he has several international scientific publications in undernutrition, marasmus, and kwashiorkor. I hope I can do justice to this great man by speaking on the same area with a different perspective in a different era. Nutrition is a critical part of health and development. Better nutrition is related to improved infant, child, and maternal health, stronger immune systems, safer pregnancy and childbirth, and lower risk of non-communicable disease later in life. Good nutrition allows children to survive, grow, develop, learn, play, participate, and contribute to economy, while malnutrition robs children of their futures and leaves young lives hanging in the balance. The term malnutrition addresses three broad groups of conditions: undernutrition, which includes wasting, stunting, and underweight; micronutrient-related malnutrition, which includes micronutrient deficiencies and excess; and overweight and obesity, and the diet-related non-communicable diseases. Globally, 144 million children under 5 suffer from stunting, 47 million children from wasting, and 38.3 million from overweight. Around 45% of the deaths among children under 5 years of age are linked to undernutrition. These mostly occur in middle and low-income countries. According to the WHO UNICEF World Bank Report 2020, Africa and Asia are affected more. Sri Lanka is a lower middle income country with a GDP per capita of $3,853 and a total population of 21.8 million, and is burdened with non-communicable disease-related illnesses. It is noteworthy to see the projected values for premature deaths due to NCDs for 2025 are higher when compared to global values. Similarly, the projected increase in the rate of obesity also shows a gradual increase when compared to the global trend, which is reducing. This serious conundrum of disease not only has been detected in adults, but in children as well. The Annual Health Bulletin 2015 of Sri Lanka reported that the prevalence of wasting was 20.3 and stunting 8.7 among primary school children. However, national data lacks the prevalence of overweight and obesity. A study done in Colombo municipal area showed 14 to 15% prevalence of overweight and obesity among 8 to 12-year-old school children. And the World Bank report in 2016 estimates 2% of the under 5 are affected by a nutritional issue. Sri Lanka has achieved several milestones in the health sector. Several steps have been taken to reduce the NCDs. Obesity and overweight are not distributed uniformly in the country, and several reports have suggested an increase, especially in the urban and semi-urban areas. The northern part of Sri Lanka, recovering from a 30-year civil war, has numerous unsolved nutrition-related problems. The health personnel, as well as the public, do not take obesity as a serious threat to their health. The lack of awareness and the lack of substantial data regarding nutritional issues in school children in this region prompted me to pay attention to the problem. Therefore, this study was designed to look at the nutritional status, body composition, and the metabolic derangement in a cohort of 5 to 16-year-old children living in Jaffna district. A community-based cross-sectional descriptive study was done among 5 to 16-year-old healthy school children in the Jaffna district. Body mass index and BMI for age Z score were used to determine the nutritional status. WHO 2007 growth references for children aged 6 to 16-year-old was used to categorize them. Maternal education, household income, family size, and the residential area were used as indicators of the socio-economic status of the family in this study. The mean Z scores distribution of height shows a normal distribution with skewness of -7.1 and kurtosis of 4.12. The weight also showed a normal distribution similarly, and the BMI Z scores showed a skewness of 1.45 with a kurtosis of 2.6. This slide shows the age distribution of various nutritional problems identified in the population. Nearly 29.8% were wasted, 11.3% stunted, and 17.4% were overweight in the study population. Stunting and wasting were significantly high in the Tenmarachi zone, which was less densely populated, but the unemployment rate was highest, accounting to 10.7 when compared to 4.1 in other areas. These results were published in the BMC Pediatrics and presented at the Sri Lanka College of Pediatricians and awarded the Dr. Gamini Karunaratne Prize. We compared our data to the published or presented data in Sri Lanka over the past years. This slide summarizes the various studies done in the recent past. It is noteworthy the children in this area are faced with a more severe and potentially life-threatening problem. When classifying the severity of the problem of malnutrition, the WHO has defined it as low, medium, and high based on the prevalence. Prevalence of stunting less than 20% indicate it as low, and our study population has a lower prevalence of stunting of 11.3%. Similarly, for wasting, if the prevalence is less than 5, it is low, 5 to 9 is medium, and 10 to 14 is high, and more than 15 is very high. In our study population, the prevalence was 29.8, indicating a significant public health issue. Studies have demonstrated that cutoff values based on BMI is a poor indicator of percentage fat, and the commonly used cutoff values were not sensitive to detect cases of childhood obesity in Sri Lankan children. It also demonstrated that including overweight and obesity may predict better outcome of Sri Lankan children. Hence, in our study, we combined the overweight and obesity together. The prevalence of overweight and obesity combined was 17.3. According to the WHO UNICEF, prevalence of overweight above 15 indicates very high rates in under 5 years. This high prevalence of overweight and obesity and the high prevalence of undernutrition demonstrates the existence of double burden of malnutrition in this part of the country. Furthermore, a rising trend of overweight and obesity could contribute to an increase in cardiometabolic risk in future. Looking at anemia in the population, the mean hemoglobin between males and females showed a significant difference. Prevalence of anemia in the study population was 27.9%. Nearly 60.5% of the anemia in the study was due to iron deficiency. Tenmarachi zone had significantly high prevalence than other zones. Even the main cause of anemia in the study population is iron deficiency. Nearly 40% of the time, the cause for the anemia was not clear. This is anticipated to be due to other causes of non-iron deficiency like hemoglobinopathies, which needs to be evaluated in these regions. These results were published in the Sri Lanka Journal of Child Health and presented at the scientific sessions of the Jaffna Medical Association. This slide shows the maternal education level and family income to have a significant association with stunting, wasting, overweight, and obesity. And the family size contributed to wasting, overweight, and obesity, but not to stunting. In view of assessing the health consequences related to overweight in this part of the country, we undertook a series of evaluations to assess the relationship of metabolic derangements and the body compositions of the study population. In humans, body compositions varies depending on the ethnicity, sex, and age. Classifying overweight and obesity based on the BMI has a drawback, as it assesses the entire body mass of an individual rather than a component of fat mass or fat-free mass. Individuals with same BMI could have different amounts of fat mass and fat-free mass. Hattori in 1991 for the first time graphically presented body composition based on the fat mass index and fat-free mass index. The BMI value can result from various combinations of fat mass index and fat-free mass index. Fat mass was derived by an in-body 230 using the bioelectrical impedance technology. Assessment made by this machine were validated against two independent Sri Lankan-based body composition assessment technique, which showed good correlation. Hattori plot for the whole study population shows a distinctive difference of distribution between males and females. But the pattern of distribution of fat is similar in males and females. In both groups, there was a more vertical gain in the chart than horizontal gain, demonstrating that with advancing age, the gain in weight in children was more due to accumulation of fat rather than fat-free mass. This slide shows comparative Hattori plots for children. The UK and USA show more horizontal distribution, whereas the previous Sri Lankan study done by Vikramasinghe in 2012 and our study show a vertical distribution. The graphic analysis indicate that a given BMI can embrace a wide range of fatness in each sex. It showed a marked variation in percentage fat mass for the same BMI value. Non-communicable diseases. Fat deposition in the liver liposomes and increased adipose tissue activates monocyte differentiation into macrophages and promotes secretion of inflammatory factors like IL-6 and tumor necrosis factor alpha, resulting in insulin resistance in adipocytes and liver. Increased secretion of cytokines from the adipocytes promote liver fibrogenesis, and exosomes released from dysfunctional and hypertrophic adipocytes impair functions of vascular endothelial cells, leading to complications. Sri Lanka is burdened with non-communicable disease-related illness, and according to WHO statistics, nearly 83% of the premature deaths are due to NCD-related diseases. The predicted premature deaths, as well as the 2016 mortality rate, were higher when compared to global values. Metabolic derangements related to NCDs are not only seen in adults, but are seen in children as young as 5 years. There are many unanswered questions when considering the metabolic derangements in children, especially the lack of age and sex-appropriate normal values. Early appearance of metabolic derangements and the longer time of exposure of the derangement will lead to more severe endpoint. A single metabolic derangement, too, can increase the risk irrespective of metabolic syndrome. The Bogalusa heart study demonstrated that every single risk factor increases the development and severity of atherosclerotic lesions. Treating a single derangement independently from the definition of metabolic syndrome is advocated by the American Academy of Pediatrics. The relationship between various metabolic derangements and the body composition has been observed since early 19th century. Gerard Raven, in his 1988 Banting lecture, propounded the theory that central obesity, diabetes, and hypertension have a common cause in insulin resistance and impaired glucose tolerance. Initially titled Syndrome X, the constellation of symptoms is now known as the metabolic syndrome. Metabolic syndrome in adults consists of subset of at least 3 out of the 5 risk factors mentioned. Over time, several criteria have been laid to diagnose metabolic syndrome in adults. Despite this vast literature, metabolic syndrome remains a controversial topic in pediatrics for several reasons. Metabolic syndrome is challenging to define in pediatric population. Several definitions were proposed periodically, and in 2007, IDF described the criteria for children 10 to 16-year-old. It is noteworthy that an adult definition used by the IDF cannot simply be applied for use in children and adolescents because drastic changes in body size and proportion occur with age and development. Another limitation was the IDF's suggestion that metabolic syndrome cannot be diagnosed in children younger than age 10 years. The main factor contributing to the absence of a consensus definition in children is the lack of reference values for some of the components of metabolic syndrome. In view of finding some of the answers to the challenges, we took further analysis, and the objectives were to determine the metabolic derangement of the study population, identify the children with metabolic syndrome, determine the sensitivity and specificity of various cutoff values, and to establish a population reference values. International Diabetic Federation definitions were used to determine the metabolic syndrome based on the age group specific cutoff values. Central obesity was defined as waist circumference more than 90th centile in the UK standards. Abnormal homeostasis in glucose, HDL, triglycerides, and elevated blood pressure were considered as shown here. Acanthosis in children was diagnosed by visualization of the dark pigmented elevated skin around the neck and axilla. This table shows the number of metabolic derangements seen in children. Nearly 43% of the children had at least one metabolic derangement. Most of these children were neither overweight nor obese. Metabolic derangements based on age and sex is shown in this slide. Prevalence of high fasting blood sugar was predominantly seen in older children when compared to the young, and females were affected more. Metabolic derangements were seen in children as young as 5 years, which indicates that there is a serious problem in these parts. Mean fasting blood sugar showed a significant increase in children who were obese when compared to non-obese children, even though none of them had over diabetes. All components of the lipid profile and the systolic blood pressure showed a significant increase in obesity when compared to non-obese children. A systematic analysis looking at the prevalence on metabolic syndrome showed in children it was 3.3 and overweight children it was 11.9. It also demonstrated boys and older children were affected more. A study done in Western Province in 2016 showed a prevalence of 1.6%. Metabolic syndrome defined by the IDF was seen in 9% of the study population. and nearly 50% of the overweight and obese children had metabolic syndrome, which is highest among all the reported studies. All children with metabolic syndrome in the category of 5 to 10 years were either obese or overweight. Even though IDF stated that metabolic syndrome should not be screened in less than 10 years in our population, the younger children too had it. Our data was compared to the study done in Western Province in 2012, and within a space of 5 years, the obesity and the presence of metabolic syndrome have almost doubled. This validates the point that obesity and metabolic syndrome are on the rise. Use of a single cutoff value for each metabolic parameter will lower the sensitivity, as norms would depend on the age and sex of the children. Our results also confirm a relatively low sensitivity and high specificity. Hence, we conclude age and sex-specific cutoff values should be used for diagnosis of metabolic parameters in order to improve diagnosis and for early detection of related complications. We redefined the metabolic derangement based on the population values, considering the different age categories, determining centile values of the study population. More than 90th centile was considered for waist circumference, triglycerides, blood pressure, fasting blood sugar, and insulin resistance. Less than 10 centile was considered for HDL cholesterol. These graphs show the metabolic derangement reference values and centile curve values for lipid profile, fasting blood sugar, systolic and diastolic blood pressure. Based on the 90th percentile values of the metabolic parameters of the study population, the number of metabolic derangements that were seen in a single individual were determined. This had a marked difference when compared to the number of metabolic derangements identified by the IDF-defined cutoff values. Prevalence of one metabolic derangement was seen in 13.4% of the population when using population cutoff and 42.8% when using the IDF cutoff values. Main reason for the high value when using IDF was contributed by the low HDL levels. This high number disappeared when population-based 10th centile cutoff was used for HDL cholesterol. Hence, we conclude that there is a need for cutoff values specific for our population. Wider range studies involving the whole country is recommended. Then, we use these cutoff values to define endpoints in body composition. Several studies have tried to determine the percentage fat mass in children that will cause metabolic syndrome. William et al. Studied a group of 5 to 15-year-old American children and concluded a percentage fat more than 25 in boys and more than 30 in girls are indicative of risk. Similarly, Dwyer and Blizzard studied a group of 9 to 15-year-old Australian children and showed the percentage fat mass of more than 13 females and more than 20 in males. A study done by Vikramasinghe et al. In 2016, a cohort of 5 to 15-year-old determined a cutoff value for percentage body fat as 28.6 for boys and 33.7 for girls. Metabolic derangements were based on the IDF cutoff values in these studies. We determined the percentage body fat based on the criteria defined as waist circumference more than 90th centile and two of the following as metabolic syndrome, HDL less than 10 centile, triglycerides more than 90th, systolic or diastolic blood pressure more than 90th, fasting blood sugar or HOMA-IR above 90th. ROC curves were created for percentage body fat and presence of two metabolic derangements, along with the waist circumference of more than 90th centile, separate for boys and girls. Percentage fat mass for 5 to 10-year-old females was 20.7 and males was 18.3. In older group, the females had percentage fat mass of 25.2 and males it was 24.8. The respective sensitivity and specificity are shown in this table. The second table shows the comparative values of percentage fat mass. This again shows that the study population is at a risk of developing metabolic syndrome at a lower fat percentage, validating the seriousness of this problem. Insulin resistance plays a major pathogenic role in the development of metabolic syndrome, leading to type 2 diabetes, hypertension, dyslipidemia, and hypercoagulable state. Insulin resistance, the compensatory hyperinsulinemia, and other components are associated with increased risk of cardiovascular disease. It has been found that beta cell dysfunction occurs in obese children and adolescents due to ectopic fat deposition. Significant amount of beta cells must be destroyed to observe impaired fasting glucose levels. Pre-diabetic situations can be detected by monitoring the insulin resistance. This graph shows the relationship of pre-diabetes and insulin resistance. Most used method to evaluate insulin resistance in both clinical and research settings are fasting, plasma insulin, and HOMA-IR. These have been shown to correlate well and have been validated in childhood with euglycemic clamp states. It is important to know the prevalence of insulin resistance in the pediatric population so that clinical consequences during childhood will increase the awareness among the healthcare professionals to prevent type 2 diabetes and metabolic complications. We evaluated fasting insulin and insulin resistance in the study population. Insulin markers and fasting blood sugar levels significantly show an increase in obese children when compared to non-obese children. Despite these, all the children were in the euglycemic state. Higher levels of insulin is required to maintain normoglycemia, especially in children with increased adiposity. Acanthosis nigricans, a marker of insulin resistance, was seen in 136 children. Of these, 79 of them had at least one metabolic derangement. Mean HOMA-IR for the presence of Acanthosis nigricans was 5.6 with a standard deviation of 0.5, which was significantly higher when compared to children who did not have Acanthosis nigricans. This validates that acanthosis has to be taken seriously in children. It was noted that children with normoglycemia had different fasting insulin, some even having very high values, indicating that insulin resistance may develop before overt hyperglycemia. This highlights the use of fasting insulin as a screening tool to detect insulin resistance, especially in pre-diabetic state. Insulin resistance has shown a significant correlation with increase in BMI, waist circumference, and percentage body fat. Insulin resistance depicted by the HOMA-IR values varies between various population groups. It has been a useful tool to detect children and adolescents with metabolic syndrome. HOMA-IR values were increasing with the number of metabolic derangements in the study population. That graph describes the number of metabolic derangements to the insulin resistance, and the statistically significant steep increase is seen when the number of metabolic derangements increase from 1 to 2. Fasting insulin levels are primarily used to assess insulin sensitivity. Impaired insulin sensitivity precedes glucose intolerance in the development of type 2 diabetes. Elevated fasting insulin is a compensatory mechanism to prevent glucose intolerance and diabetes. Fasting insulin as a biomarker for 2 metabolic derangements was 7.35, and for 1 metabolic derangement was 5.34, with a sensitivity of 0.65 and a specificity of 0.76. This study concludes that fasting insulin and insulin resistance can be used as screening tools to detect metabolic derangements. We do not propose to discard the criteria to diagnose metabolic syndrome, but suggest that elevated fasting insulin should alert pediatricians in the clinical settings. Some of these findings were published in the Jaffna Medical Journal, presented at scientific session of the SLCP, and awards received are mentioned here. Inflammatory state that accompanies the metabolic syndrome shows a quite peculiar presentation. Complex interplay between obesity, inflammation, and metabolic syndrome potentiates the transcription of inflammatory genes. Adipocyte hypertrophy leads to oxidative stress and release of inflammatory cytokines. CRP, a non-specific marker of inflammation, is typically low or undetectable in healthy subjects. However, it can increase up to 100 times during acute illness or inflammation. These acute phase reactants have been studied as potential markers of cardiovascular disease in recent years. This table shows plasma high sensitivity CRP levels are significantly positively correlated with body weight, BMI, plasma triglycerides, insulin levels, insulin resistance index, and negatively correlated with HDLC cholesterol levels in the absence of infection in healthy children. CRP, a cost-effective test, can be used as a marker for detecting metabolic syndrome. Non-alcoholic fatty liver disease, the liver involvement with metabolic syndrome has rapidly become the most common form of chronic liver disease in children and adolescents. A total of 176 children were screened among the obese children for NAFLD. A total of 26.7% of the obese population had NAFLD. Nearly 21% of the children had fatty liver and elevated liver enzymes. Ladies and gentlemen, we felt it was our moral obligation to inform all the research participants of their results and indicate the necessity of follow-up. Nearly 421 children with anemia, wasting, overweight, obesity, and metabolic derangement attended a clinic in the tertiary care center. A total of 176 children with either overweight or obesity from the community survey were followed at the obesity clinic every 3 months to assess the progress. Regular advice from a dietitian along with a care plan to reduce or maintain weight was encouraged. Written care plans were given to the family during the first visit. A total of 85, 48.3% children were followed till the end of 1 year. The rest dropped out of the clinic. This slide shows the BMI and BMI-Z scores of the children. Even though there were slight variations in the BMI during follow-up, significant changes were not seen in the age and sex-specific BMI. As children are a growing population, the static nature of the BMI itself may be beneficial. The conclusions from this study are a public health concerns of stunting, wasting, and obesity is seen in this part of the country. Metabolic derangements are seen in children less than 10 years. Metabolic syndrome is seen in nearly 50% of the overweight and obese population. Using recommended cutoff values is not suitable to our population. Population-based cutoff values for percentage body fat are better predictors of metabolic syndrome. Insulin resistance develops before hyperglycemia and is seen in young children. Insulin markers and inflammatory markers can be used to predict metabolic derangements in resource-poor settings. It is pertinent to be aware of the future directions to control NCD-related diseases and consider primordial preventive measures such as promoting a healthy lifestyle. Screening tools must be developed to detect early metabolic abnormality in order to prevent detrimental effects in later life. Recent evidences suggest that metabolic disease such as obesity, type 2 diabetes, hypertension, and coronary artery disease are related to developmental programming in fetal period and early childhood. Rapid postnatal catch-up growth is also an important factor that contributes to the development of these long-term metabolic complications. Early nutrition and weaning practices must be geared to prevent rapid weight gain, especially in underweight children. This slide demonstrates the current BMI was more detrimental than the initial birth weight. If born small, it is anticipated to remain small to be safe rather than have a catch-up growth. Our study also demonstrated that even if you are born small, there is a risk of metabolic derangement, irrespective of the current state of the high BMI. Childhood obesity is a disease of the environment. It is a natural consequence of normal children with normal genes being raised in an unhealthy, abnormal environment. The first 1,000 days of a child is crucial in this regard. In addition to the nutritive value of the food, the current research also has explored the possibility of the role of microbial taxa in the preventing the complications of malnutrition. Garrick et al. In their research published in the Science demonstrated that diets designed to modify the microbiota into a mature state might support healthy growth of children.